phytosterol levels are significantly increased in people who are taking a statin. And this phytosterol is causing damage and harm that has not been properly investigated. With regards to the canola oil, the FDA gives it permission that it can have roughly about 3.5% of trans fat in it. But the canola oil industry said that if we say that we have trans fat in it, then we are doomed. For every 14 grams, if the amount of trans fat in them is about less than 0.7 grams, you can label it as zero trans fat. At some point with insulin resistance, the fat cells become overstuffed and those fat cells become inflamed. The extra fat that is left in the bloodstream causes the very lipotoxicity that I talk about. Lipotoxicity is potentially one of the mechanisms for aging, vascular degeneration, and organ degeneration. When we talk about increasing fat intake and going on a low carb, high fat diet, we are addressing metabolically healthy people. If you are metabolically not healthy, you have inflamed fat cells, you have ectopic fat deposition, you have high triglycerides. The initial strategy, the way I would individualize these patients, is for them to focus more on.
Given all the conflicting information out there when it comes to the optimal diet for humans, how does somebody begin to navigate this and figure out what they're supposed to eat to optimize their health?
Excellent question, Jesse. We had a almost 2-hour conversation last time about 3 months ago, and I'm glad that you found reasons to call me back. There were over 500 questions from the podcast that you posted. And this is a perfect way to start. What is optimal diet for humans? And I can give you a little bit of a scientific answer to begin with, and then we can extrapolate on that. So the scientific answer is to look at the human gut. The human gut is not very specialized at processing food. In other words, we cannot take low quality nutrients, fiber would be a low quality nutrient, and process it properly. What we do have is an extensive absorptive surface. That means we can absorb nutrients that are high quality without necessarily pre-processing them. In fact, there is a controversial theory called the expensive tissue hypothesis. And the expensive tissue hypothesis says that our brain enlarged from roughly around 400 400 grams to about 1500 grams over a span of a few centuries because of the animal food that we ate. And not only did we eat animal food, but we learned to do one very important thing, and that is that we cooked the animal food. Cooking was a very important aspect of pre-digesting the food outside the body. So the stomach, which has pepsin, which can break down protein, which has acid, which can break down protein, doesn't have to do as much work as many carnivores have to do. Like cats, when they eat raw meat, they have to process that raw meat through acid digestion, through pepsin that is breaking down the protein to individual amino acids before they absorb it. Humans have the advantage of cooking their food and pre-digesting it or pre-breaking it down so that the small intestines, which is the largest part of the human gut, can do efficient absorption of these nutrients to feed our brain, to let the brain grow. In fact, there is information out there that says that since modern civilization have come on, our brain size has shrunk a little bit. And I wonder if the shrinking of the brain size is related to the fact that we are eating more and more food that is plant-based, that is not of high nutrient quality, that we have to process. To elaborate that a little further, if you look at an animal like a horse or a primate that is used to eating mostly plant-based diet, they have an enormous colon. Their colon size is ginormous. And their small intestines are small because they're processing the fiber in the colon. The colon has bacteria. The bacteria breaks down the fiber to small chain fatty acids. So, in fact, when these animals are eating fiber, it is like they're eating fat. And fat is what is giving them nutrients and calories. On the other hand, if you normalize human colon and compare it with a primate colon that is eating predominantly plant based food, our colon is about 10% their size. Whereas 56% of our gut is devoted to small intestines, which are bacteria free, and they are designed to absorb high quality protein, fat, and carbs. So I'm not saying carbs is completely eliminated, but I really think that human evolution and human brain size increased because we learned to eat high quality animal food and we got nutrients, and that's how we were able to take in the energy without having to burn extra energy. We didn't have to process food. So I highly encourage people to consider eating predominantly an animal based diet. And I don't have objections to adding small amounts of above ground vegetables if constipation is an issue, that you don't feel regular, that not being able to use the bathroom easily becomes an issue or a problem. Although, if you talk to most carnivores, they say that that is not an issue as long as you drink plenty of fluid, as long as you modulate your fat intake upwards. In other words, if you're getting constipated, increase your fat intake, that get rid of constipation. And in some people, they can take a little bit of magnesium, and that also helps. So that's a kind of a overview of what we should eat. And I don't know if you had any specific elaboration on this, Jesse.
Well, given what you said there about the anatomy and the physiology and the way it works for humans, is there anything that we're getting from plants that we need that's different than what we could get from animals? You mentioned constipation, but again, with proper hydration, with getting enough fat, is there anything that carnivore would be missing out on specifically that they need to thrive that they would get from plants?
That is an extremely good question. And for many people, it is the opposite. In other words, for most carnivores, they have gone to a carnivore specific diet because plants have caused some kind of a problem in them. It has elicited an immunologic response. It has caused some issue with their body because plants have toxins. Like we talked about before, plants can defend themselves not through fangs or claws or some kind of physical physical way to kill their prey, but they do biologic warfare. They do chemical warfare. They have toxins in them. Phytates is one of them. And these can prevent absorption of important nutrients. There are other plant based toxins like lectins that can damage us. And another way through which plants can mess us up is by diluting the stomach acid. So many people who are used to eating large amounts of raw vegetables, they're taking in bacteria along with the vegetables that they are eating. And the stomach acid is an ecological barrier that is designed to kill the bacteria before they enter the small intestines. So the small intestines are considered to be what I would call as bacteria free. And if you eat a lot of plant food, especially raw plant food, you may overwhelm the capacity of the stomach acid to neutralize it. And you may be introducing bacteria into your small intestines. And that can cause inflammation in the small intestines and lead to SIBO. So I took it from a standpoint in which I'm saying that, hey, be careful with a lot of plant food because you may be harming and damaging yourself by the mechanisms that I described. But there's a contrary opinion also. And the contrary opinion comes from a few very well done studies in humans in whom they were changed from like a regular omnivore diet that included both plants and animal food to a completely animal food diet. And I was shocked to see in that study that the gut bacteria, the bacteria in the colon, changed within a matter of 48 to 72 hours. So the kind of bacteria you had there was completely different. And in that paper, they argued that the colon receives some of its nutrient supply by the breakdown of fiber by the gut bacteria when they make small chain fatty acids. So, if you're not eating, let's say, even the most minimal amount of fiber, it is possible that you will starve the lining of the colon from a nutrient standpoint because you're not making any of the short chain fatty acids. I'm not sure how clinically relevant that is because there are a number of carnivores ever since this revolution started, and they do just fine. But if somebody comes to me and says that I feel individually and personally a little bit better by consuming small amounts of fiber and small amounts of carbs, I don't think that we should be so rigid because the human digestion is designed not to be a complete carnivore, but there is options of being an omnivore also. So I don't want to go that rigid and say carnivore is the best diet. You don't need plants at all for every single individual. I don't think our knowledge is that refined and good at this point. On the other hand, if you're like Michaela Peterson, then absolutely be on a complete carnivore diet because the plants are toxic to you. You're too sensitive to them.
While you bring her up, it brings up for me the fact that she came to this diet from a place of being sick, which we can't ignore the individual aspect of where a person's coming to this information, such as what we're bringing forward today. Are they metabolically healthy? Do they have a chronic disease? Versus somebody who is taking on eating this optimal diet from a place of health. So I think we need to look at the individual person and what their body's been through and what healing it needs when we're deciding on this optimal diet. And it's not going to be a one size fits all.
I couldn't agree more. Diet has to be individualized. Now, if you come from a situation in which you have autoimmune disease, you have psoriasis, you have rheumatoid arthritis, lupus, some other joint manifestation, some other inflammatory disease from which you're suffering, polymyositis, then an exclusionary diet, in other words, eat something that would cause the least degree of inflammation. And that would include not just a carnivore diet, but a specific version of the carnivore diet, which is called the lion's diet. A lion's diet is one in which you're eating nothing but meat, salt, and water. And from there on, once you improve your health, then start adding different animal food in there, maybe dairy, maybe eggs, maybe ham, pork, chicken, and see if that is messing up your health. And if it is not, that means that you have this range of diet that you can follow. But there may be a situation in which your body is so sensitive to the anti nutrients or the substances in this diet that you may not be able to tolerate anything but the lion's diet, which is what Michaela Peterson is on. On the other hand, if you're coming from a situation of health, and a situation of health meaning that you feel good, your body weight is good, your muscle mass is good, you are insulin sensitive, your cholesterol quality is excellent, your blood sugars are fine, you don't have any inflammation, then you are free to try an omnivorous diet with a range of food that is available to you. So I am completely a proponent of individualized diet. If somebody comes to me who is metabolically healthy, then I don't try to change their diet.
If you're enjoying this episode, take a second and let me know by clicking like and subscribe below. Thank you so much, and now back to the show. Coming back to the plant toxin piece, you mentioned phytates. There's also, lectins, oxalates. We could go on and on. Do you find that if a person is healthy, they can tolerate those to a certain point? Because you have this continuum in our world of people that say avoid them at all costs, that it's BS and we don't need to worry about them. Again, everything we're going to talk about today has to be with the caveat of it depends on the person and their health status at that time. But in a general sense, for a healthy person, quote unquote, how big of an issue do you find those?
Very good question. For example, many people sell something called lectin shields, uh, you know, supplements that you can take. And I would say perhaps for the majority of people, they are completely unnecessary because you know that when you take a food that is high in lectins, like let's say beans, and you soak them overnight in water or you cook them for a specific amount of time at high heat, like for about an hour, all those lectins are neutralized. And the vast majority of healthy individuals can take them without any problems. Same is the case with phytates. So, phytates are found in nuts. Now, unless you're eating raw nuts, which I would not advise, but if you roast the nuts or if you soak them overnight, the phytates similarly get neutralized and they don't bind calcium and magnesium. They don't prevent protein from getting absorbed. So I would say yes, that you can do certain things to food which in normal healthy individuals would negate the adverse effects of phytates and of lectins. Oxalates may be a slightly different story in people who are susceptible to kidney stones. And I'm not sure if there is enough data to implicate oxalates in coronary calcification. In other words, plaque buildup and calcium buildup in the blood vessels of the heart or vascular system in general. But people who have kidney stones should definitely try to avoid oxalates, which would be found in leafy green vegetables, in nuts, in certain kinds of teas. And it's perhaps always good to modulate the amount of oxalates that you're taking. So, there are several individuals who just listen to somebody who is a plant-based, whole food plant-based, uh, expert who is recommending that kind of a diet, and they just eat nothing but spinach and broccoli and other leafy green vegetables. And I think these people are in significant danger of getting a kidney stone or getting some other health issues as a result of the way they are eating.
Argument I could see somebody making, and I'm not saying this is where I stand, but hormesis. So these plant toxins in small amounts, whatever that is, could they be having a positive effect, just like going in the sauna or exercising or doing these different fasting? We could go on, these different stressors that are considered healthy. So if we got the right amount, could that be a healthy thing for the body?
That's a very interesting and provocative view that we should look into. I have not myself read any studies that talk about hormesis coming from the right amount of phytates and lectins and oxalates, but it is possible. So I'm not going to say that that theory is not valid. I just need to investigate it further.
And we know that when someone's on a plant-based diet, there are certain nutrients they're not going to be getting that are found only in animal products. But this ties back to a question I had before. Do you feel like there's anything specifically the other way around where, whether it be polyphenols or something specific that's a phytochemical, that a carnivore or somebody who is basically avoiding plants could be missing out on? And the polyphenol piece, I've actually heard from Dr. Gundry, I believe, that depending on what the animal's eating, that meat will contain some polyphenols. So it's very intricate, but I'm just curious, do you find from many of the research you've done, there's anything in plants, of course, fiber, which we touched on last time and you've touched on it quickly today, but I know you're not a big fan of that. Anything specific we could be missing out on that's only in plants?
So I give you two substances with a question mark. In other words, we are not sure if these are actually completely required and missing from an animal sourced food or animal sourced diet. So one of them would be vitamin C. Vitamin C levels in meat may be not as much as what is the recommended daily allowance for humans. However, there has been extensive studies that Amber O'Hearn has evaluated, and I heard one of her talks in which she says that when you are on an animal sourced food diet, the requirement for vitamin C goes down. So taking less vitamin C would be okay in that situation. But it is possible that you would be vitamin C deficient from a recommended daily allowance if you were taking a complete animal sourced food diet. The number two one is the one that I already alluded to, which is that the lining of the large colon perhaps gets its nutrient supply from small chain fatty acids that are a fermentation product of fiber by the colonic bacteria. So, given apart from those two caveats, flavonoids, whether they are actually necessary or no as antioxidants, are they superfood? Do we really need them? Is a huge question because we attribute a lot of benefit to various different kinds of foods in terms of antioxidant ability and the nutrients that they contain, but whether it actually translates into a clinical in vivo benefit, in other words benefit inside the human body, is perhaps unknown. And I think that the best antioxidants are made in the human body itself. As you are making cholesterol, you improve antioxidant enzymes. HDL is a very strong antioxidant. LDL is a very good antioxidant. So there are many antioxidants that we make which are perhaps far superior than the antioxidant ability that we are assigning to various fruits and other chemicals that we are ingesting.
How do you feel about organ meats? You'd have to
Organ.
assume over our evolution as humans, we wouldn't be wasting parts of the animal, and we know they're nutrient dense. Are you somebody that in supplement form or in whole food form includes those in your diet?
I definitely don't include them in a supplement form. So many people take liver extract. I'm not sure I'm completely convinced that that helps. As far as nose to tail eating, there may be some element of value to that. So rather than just eating muscle meat, whether you should have small portions of the liver, the kidneys, the brain, the tongue, certainly the bones and the bone broth, I think that applies. But I would say that I don't have the degree of expertise in animal sourced food to say that if you don't eat organ meat, you have to have some supplements that are supplementing what you would miss out from the organ meats. I have not gotten to that level. And like, for example, when I have a conversation with Sean Baker, he says that that is absolutely not necessary, that eating muscle meat is more than enough for the vast majority of people to remain healthy. So I think the jury is still out on that. I would like to have a few more experts weigh in on it with some definitive evidence and not just conjecture and opinion.
Another potential hazard from plants are plant sterols or plant cholesterol. And I know this is an area that you've delved into and shared quite a bit on over the internet. Talk about what those are and when they become problematic.
It's a very good question. I had put out a YouTube video which talked about the danger of plant cholesterol. So, plant food does not have any cholesterol, but they do have sterols. And instead of being called cholesterol, they're called phytosterols. So, when you take olive oil, you are consuming phytosterols. When you eat avocado, you're taking a large amount of phytosterols. And cholesterol is not only a part of several hormones in our body, but it's an integral component of the membrane of every cell. So, in other words, the outer lining of all the cells that we are made up of will have a significant component of cholesterol that is giving the membrane fluidity, the right degree of rigidity, and that cholesterol is involved in signaling between cells. In other words, receptors that make one cell communicate with another cell are held together by cholesterol in the cell membrane. Right? These are called lipid rafts. The lipid raft theory, whether it is accurate or no, has been a subject of controversy, but most people think that there is some merit to it. For example, the insulin receptor sits in a part of the cell membrane that is very cholesterol rich. And one of the theories is that when you take a statin, you reduce the amount of cholesterol in the cell membrane, and the insulin receptor doesn't sit in the right orientation, and that's why you become insulin resistant. Now, there are a certain group of individuals who get what is called cytosterolemia. Cytosterolemia means that they have absorbed a large amount of plant cholesterol, phytosterols, and have replaced a portion of their cell membrane. Instead of it having cholesterol, it now has phytosterols. And when you have phytosterols in your cell membrane, the cell does not behave well. It doesn't have the kind of fluidity, it doesn't have the appropriate structure. The receptors are not oriented in the proper fashion, and these cells tend to malfunction. If they're red blood cells that are replaced with phytosterols, they have a shorter lifespan. They don't live as long, so you can run into all kinds of problems. We have an active mechanism in our gut. So if you look at the human digestive tract, especially the small intestines, there is a Niemann-Pick receptor, if I'm thinking correctly. When it picks up a phytosterol, it has a mechanism of actively spitting it back into the lumen so that we don't absorb it. And that's a very important concept for people to understand. And it's a very important concept to be taught in cardiology fellowships also. And there is a reason why I'm saying that. The body will make cholesterol if you don't eat cholesterol. Making cholesterol is a very expensive process. Like we discussed before, there are about 25 different enzymatic steps through which it makes cholesterol. And if you don't eat animal food, the body will be forced to make cholesterol, which is energy wise very expensive for it. And if you are on a plant based diet and you are taking a statin, not only are you not eating cholesterol, but with the use of a statin, you're stopping cholesterol production in several parts of your body, specifically in the liver, more specifically in the brain. And the body says, I am in a crisis. I cannot make cholesterol and I cannot absorb cholesterol. So, in that situation, the body becomes indiscriminate. When I say indiscriminate, it means that the active mechanisms to spit out the phytosterols is overwhelmed. And the body says, if I can't get cholesterol, let me see if phytosterol will work. I would say that 99.9% of cardiologists, if you interviewed them, would be unaware that phytosterol levels are significantly increased in people who are taking a statin. And this phytosterol, in my mind, is causing untold damage and harm that has not been properly investigated. So that is my hesitation that people are on a large amount of vegetable oils that will have phytosterols. They'll be eating avocados in order to avoid animal food and yet taking high dose statins and maybe doing harm to themselves, which has not been investigated properly. And that is a danger that, as a group of individuals who are interested in improving our health through lifestyle, we should recognize and modulate and force NIH or some other important body to investigate.
To me, there's three different variables I want to explore within this. One being a diet exclusively or very high in these plant cholesterol type molecules. Two, somebody on statins or not on statins. So basically with those two pieces, if you have somebody that isn't taking cholesterol in through the diet because they're only on plant-based, and say they're having a concentrated form of these phytosterols, but they're not on a statin, could that still overwhelm the system? Because they're taking in a lot through the diet. We'll take the statin aside right now. They're not taking in any regular cholesterol through animal products. Basically, I want to look at it from different angles and overwhelming the system with different variables. So, and we can also look at that. What if somebody's having less in the diet and they're having an omnivore diet, but they are on a statin? So their mechanism for disposing of the phytosterols isn't working properly. So we can look at it again. There's a couple angles there. There might even be other angles that we can look at this and in try and determine whether or not there's different situations this could be a problem. Because you talked about oil quickly and you mentioned olive oil and then also seed oils. These are products that are, to some degree or another, depending on which one we're talking about, refined. So would this be a problem if we weren't having the oils and we were only eating whole foods? That's another angle. There's so many different angles we could look at this. And why I want to explore it this way is just to see if somebody is taking a statin, not taking a statin, having a diet that's extreme in one way or another, whether or not these phytosterols could become problematic for them.
Very intriguing. And I wish I could give you definitive answers on that, but I could kind of shed some light. So let's take the first scenario that you pointed out. A person on a predominantly plant-based diet but not taking a statin. So in that situation, you could do Berkeley labs and there are markers in the blood of phytosterols. So that means you are an overabsorber. You're absorbing these phytosterols into your system. And you could see whether you are getting a high degree of phytosterols in your system. And you might be that particular individual because not all of us are the same. Some of us are hyperabsorbers and we are indiscriminate in whether we choose to pick cholesterol or phytosterols. And you can find that information by doing a specific test. Berkeley Labs has a very good way of looking at markers of phytosterols. But whether there is data already that people on a plant-based diet without the use of statins, whether they have high markers of phytosterols in their blood, I don't know that. I would have to investigate that. The second question that you asked is that there is somebody who's an omnivore. In other words, he's eating both animal food and plant based food and is on a statin. Would that person be indiscriminate in terms of absorbing phytosterols? The answer to that is yes. There is clinical data, research data that shows that, yeah, the markers of phytosterols would be higher in this particular situation. The third question is also very intriguing, which is that you are looking at people who are consuming a lot of phytosterols through animal fat, seed oils, avocado oil, olive oil,
Plant fat, you mean?
whether that will make a difference.
No,
Go
I was
ahead.
just saying, you said animal fat, but you mean plant fat.
Yes, I'm sorry, plant fat. Plant fat meaning seed oils and avocado oil and olive oil. Yeah. I don't know the answer to that question. I'd have to again investigate. But these are I'm hoping to watch this interview again and go back and review some of these things.
Yeah, a lot of it's just thought experiments, and I'm sure there's not good science on a lot of it, but just to throw it at you, somebody that's deep in this world, and just to get your thoughts on where we're at with all this.
Absolutely.
Next question related to the phytosterols is if somebody has incorporated those into the cell membranes, can they say they got off their statin and they changed up their diet? Have you seen any research showing if somebody starts including cholesterol through animal form, which is the only way to get it through the diet, that they can replace those phytosterols in the cell membrane with better cholesterol over time?
That's again an excellent question. And I think there is evidence, empiric evidence that exists because our human body, including the cell membrane, is not static. It's in dynamic equilibrium. In other words, cholesterol is being constantly replaced, degraded, removed through the bile, and we excrete it out as bile acids in our feces. As there is changes in protein as well as fat, so the cell membrane is being constantly replaced. And I think that with regards to seed oils, they say if you're consuming seed oils and the seed oils become a part of your cell membrane, because our cell membrane is a phospholipid bilayer. In other words, it's a fatty bilayer. And just like phytosterols, the seed oils also get incorporated into our cell membrane. And the dynamic change is apparently somewhere in the order of about 3 years. In 3 years, you may get rid of the seed oil fat that you have put into your cell membrane. I'm not sure what is the time frame for phytosterols, but perhaps it's similar, I would venture to guess. And again, this is another thought experiment. I have to look back and see if there is any timing with relationship to the dynamic change in our cell membrane structure over time as to how long it takes.
Last time we were chatting, you mentioned it being very difficult for you to eat out because of these seed oils. Talk more about seed oils as a whole and why they're so problematic.
They are significantly problematic because even at my own home, the tendency to use seed oils is so pervasive. If you get bread from the outside, any kind of bread, it would be usually made with some kind of seed oil that doesn't have any of the hydrogenated fat in it, because hydrogenated fats are bad right now. And so they say, well, we're going to not have any of the fatty acid molecules in them. But even that is an error. And I'll explain that when we talk about canola oil. The second thing is that the seed oils are so inexpensive and so easily available that even the highest quality restaurants, like for example, you go to a place that is making steaks, the seed oils can take a higher heat. So searing the steak is now done with seed oils. And I feel terrible about that because I have to go to a restaurant and tell the waiter that, hey, can I please talk to your chef? Because the waiter himself does not know. And many times you're not able to talk to the chef. And even if you do talk to them, you're not sure that any of what you are asking for is followed. Now, let's say you ask for butter at a restaurant. Many times you are given fake butter. And it's hard for you, just from a taste standpoint, at least to me, because I'm not that discerning in my taste buds, for me to recognize whether I'm getting fake butter or real butter. Because the fake butter, by design, is made from vegetable oils, polyunsaturated vegetable oils. And these are some of the reasons in which I say that it's almost impossible to eat outside, that you have to cook more or less your own food in order to be sure that you're not consuming vegetable oils in any significant quantity. And I don't know if your experience is different. Are you able to find restaurants where you can say, safely assume that you're not going to consume vegetable oils?
Not confidently. We'll ask specific questions if we're at like a Mediterranean restaurant and does your hummus contain olive oil or some other vegetable oil? And
Canola oil.
Yeah, it's very difficult.
So with regards to the canola oil, the FDA gives it labeling permission in such a way that it can have, I think, roughly about 3.5% of trans fat in it. We know that trans fat is very bad for us from multiple different studies that have been done. But the canola oil industry said that if we say that we have trans fat in it, then we are doomed. Our industry will close. So FDA told them, I think, that for every 14 grams, if the amount of trans fat in them is about less than 0.7 grams, you can label it as zero trans fat. So in other words, vegetable oils that say zero trans fat may have almost close to 4% of trans fat in them. Now go figure that out as to why that has not been informed, why the public has not been informed about this kind of labeling practices.
It's crazy. It sounds like a money thing.
Well, you got to be somewhat understanding of industry. There is canola oil industry. They may lose their jobs. They may lose their livelihood. People might not do well from that. Perhaps these big food companies can be pressured by grassroots movement to change and modulate before it becomes too late, because none of this regulation is going to come from top down. You cannot expect FDA to think about your health without balancing economy, without balancing job loss. It ain't going to happen. It's only going to happen through grassroots movements, and the grassroots movement is going to start by the consumer knowing the truth from people like you.
Well, let's expand out and talk about cooking methods. This ties into what
What
cooking
method?
methods. You talked about
Cooking
steak
method.
being seared with vegetable oil at a restaurant. I'm assuming you totally avoid deep fried foods.
Absolutely.
Talk about other methods of cooking though, like grilling on a barbecue. And if you are cooking at home, what different methods do you use to keep that quality food at its peak health and quality?
Absolutely. So let's touch a little bit about why we say frying is bad, because usually the omega-3 vegetable oil, which is ALA, which is found in fish, and the omega-6, these oils can get oxidized. So they have oxidation is a bad thing for the oil because that oil is not very good for the human body. It can increase inflammation. So omega 6 has a high oxidation potential. You get many more aldehydes when you heat vegetable oil to a high temperature. If omega 6 can get oxidized, omega 3 gets oxidized even more. So it might be useful to pause for a minute and think about canola oil, because canola oil is sold by saying that it has a higher content of omega 3, plant based omega 3 ALA, compared to the other seed oils. But when you think about it, the canola oil is then the worst because it has the highest oxidation and aldehyde potential of vegetable oils. And that's one of the reasons why you should never consume anything that is deep fried, especially from a restaurant, because their deep fryer, that oil may not be changed for a week to 10 days. And reheating vegetable oil over and over again increases the amount of oxidation and aldehydes in the oil and makes it more and more toxic. But when you look at animal fat, like beef tallow, like lard, it has a much lower oxidation potential at high heat. Animal fat, like beef tallow, can take the same degree of heat and have less oxidation products compared to vegetable oils. So that's a very important aspect. That's why you should always cook in animal fat. Butter may be an exception because butter smokes at a relatively low heat, right at around 290, maybe at about 300 F Fahrenheit. So be careful with that. Still cook in low heat when you're using butter. What are the ways in which you can cook without actually damaging the fat that you're eating, without actually messing up the food that you're eating? One of the best ways I would think is to use an Instapot. You can cook it at low heat for a longer period of time, and you can make your meat so soft, especially the older you get. It's important for you to cook your food. So many people want to eat sushi and beef tartare, which is uncooked. And I say the older you get, be more and more hesitant about this food, because as you get older, like my hair are getting gray, like the skin is sagging, like how we use our faculties in many different ways, you get presbyopia. Similarly, the amount of stomach acid that you're producing has a steep decline as you age. And if you don't have stomach acid, you're not going to process the meat that you're eating, especially if it is uncooked or partially cooked. So if a 70-year-old comes and tells me I'm going to lose weight by eating ribeye, New York strip steak, or filet mignon, I'd say, sir, you got to be careful. And I have a technique for you, which is called sous vide. So we talked about Instapot. The second way to cook your meat is in sous vide. So in sous vide, you're cooking your meat at about 130 degrees Fahrenheit for about 6 hours if it's filet. For me, it's overnight for a New York strip steak, and maybe somewhere in between for a ribeye. And what that does is that it pre-digests the meat to the just right amount, to the soft amount, so that your body does not have too much work to do in order to get the nutrients from it. And the fat that is in it is not as destroyed in terms of oxidation as it would be if you cooked it at high heat for a long time. You are not going to take the steak out from the sous vide bath and eat it directly. You will still have to sear it. So searing methods are different. And we're not getting into the nits and bits of how you cook your food. So searing, I don't like to sear food on a non-stick pan. I'm extremely careful because a non-stick pan may have some kind of material that may leach into my food. So you would have to sear it on a pan that is a carbon iron or carbon steel pan. And so that you're not getting any of the non-stick material into that food. You can put a little bit of beef tallow and try to sear it that way. I have not been very successful, although there are several YouTubers who tell you that you can do a very good job by searing the steak on a pan. It's just that it creates a large amount of mess. The oil is flying all over the place, and there is cleanup and stuff like that that I hesitate to work on. So what I do is that I put it in an air fryer, and I put it in an air fryer at about 350 to 400 degrees Fahrenheit for about 2 to 3 minutes. And for me, that gives the best degree of searing, enough searing for the meat to be extremely tasty and it not being exposed to heat for a long period of time. Those are the methods I use. Now, uh, ground beef is already somewhat pre-digested for you because it's been minced. It's been mechanically, the collagen fibers are mechanically separated. So you can use ground meat and cook it at low heat, and you don't need to add any animal fat into it while you're cooking it because it already has about 15 to 20% fat in it. And then you can add salt or whatever garnish. And so that's another way in which you can improve your quality of food without incorporating vegetable oils or without cooking it at high heat. So those are some of the tricks that you could use. Um, if you're extremely healthy, your triglycerides are low, you may start getting cream. There is English cream that you get. It comes in a small bottle. And that cream is very good. It has no preservatives. It has nothing but cream. So you're getting pure animal fat. And you could supplement your diet with that pure animal fat to meet your caloric needs and also make your food tasty. Those are some of the techniques I use, Jesse. Maybe you can add a few more of your own.
That's great. I'm curious on the barbecue. Do you ever grill meat on an open grill?
So the barbecue that I use is a grill. I'm forgetting. It's a Black & Decker grill, I think.
Is this the air fryer or something different?
It functions as an air fryer also. I could, I don't remember exactly the model number, but it's a Black & Decker grill that I use, and it's very popular. And it has a max temperature of 400 degrees Fahrenheit, and it does a beautiful job. I don't use an outside grill or a charcoal grill or a mesquite grill. I don't have time for that, but I'm sure that people can do something like that and still come out ahead.
Okay. I want to come back to the piece where you talked about somebody getting older, producing less stomach acid. What was the hack for them? You mentioned like ribeyes and New York strips, maybe having to avoid them, or was it just cooking them differently?
Oh, no, not necessarily avoiding them, but don't eat them as medium rare or rare. And don't eat them without doing sous vide because you're not going to absorb that protein. That protein is going to pass through your stomach, through your intestine, and then undigested protein is going to get into your colon, and your bacteria makeup in the colon is going to change if you let undigested protein pass from your stomach and small intestines into the colon.
How do you feel about somebody using hydrochloric acid supplements when they're going to have a meal like that?
It's a good idea. I have not tried that myself. Betaine hydrochloride is a capsule that you can take. So it will you can take it. You're not taking hydrochlorothiazide directly into your mouth or into your esophagus. The capsule is digested in the stomach, releasing hydrochloric acid. And that should, and some of these also have pepsin in them. So you can improve your digestive power by taking betaine hydrochloric chloride. And that is a method that you can use. I just have not experimented with it in any more than a few anecdotal patients of mine. So I'm not prepared to say how good that is going to work. I have relied more on pre-digesting the food outside than taking betaine hydrochloric acid, which is a very good thing that you pointed out.
Are you familiar with Dr. Anthony Chaffee, the carnivore?
Yes, I have listened to his YouTubes and I know who he is. Huge YouTube following.
And he brought up something that's really stuck with me. The fact that, and I'm paraphrasing here, he was telling me just eat the damn fat and your body will regulate how much you absorb. And if you have too much, if you're eating fatty cuts of meat, your stools will get loose. So where this comes into play with what we were just talking about, I don't think he would agree to bump up your hydrochloric acid artificially, because then you're jumping in and playing with that physiology. And this is why I was curious your thoughts on it, because your body's going to self-regulate how much fat you're absorbing if you're not supplementing. And that way you can really, he says, just eat the damn fat. You can keep upping your fat. Your body will produce a loose stool if you take in too much. But then when we start jumping in and propping up our stomach acid, I could see how that would start to tamper with that mechanism, and potentially would we have to start being more weary of how much fat we're taking in because we're propping it up. It's, again, a thought experiment. I'm just curious how you think about that.
Well, of course, Dr. Chaffee is an Olympic athlete. He is in extremely good shape. He's, I think, quite young. So maybe his point of reference is more related to young people who are already healthy to begin with. So I see a large number of patients that are metabolically not very healthy. So in those people, have several YouTube videos that talk about lipotoxicity or fat toxicity in people who are insulin resistant, overweight, and have high triglycerides, how in whom a large consumption of fat may be not very good for them. So, but let's take those individuals out. Let's say we are only prescribing this method of eating to healthy individuals, metabolically healthy individuals. And even in these people, when you go up too much on the fat, the kind of oily diarrhea and the abdominal discomfort that they have is quite distressing. So it's not like just you increase the fat and nothing terrible happens. You would get these people coming back and telling you how bad they felt. So I would say that older people perhaps need to be a lot more careful about pre-digesting their food and being careful about the amount of fat that they are eating. And at least that has been my clinical experience, because my practice is probably geared a little bit more, skewed a little bit more towards older people, older patients. And so I would hesitate to say, just eat the fat. Don't worry about how you cook your steak and things like that.
Right. I would hope if somebody did push it to that limit and they got the runs, that they would learn from that and not keep doing it. But to test, I can see how that could be valuable for somebody to test their biology and see what their tolerance is. And again, using that as a system when we're not propping it up with a supplement like HCl, to let our body take the fat it needs and then expel the rest.
And I couldn't agree with that more. So I'm sure Dr. Chaffee has a large amount of experience because he's been a carnivore for a long time and his advice is very valuable. But I'd like to throw one other important thing in the mix, which is an extremely common situation that people are going to run across. And that is the use of proton pump inhibitors. These are called PPIs, Prevacid, Protonix, These are some of the trade names that you would come across. And what they do is that they make your stomach acid zero. And when they make your stomach acid zero, just imagine the kind of damage. And these people, once they get on these proton pump inhibitors, they're not on it for 2 to 3 weeks or 4 weeks, as was the original thought experiment or original plan with these drugs. They are on it for months to years. And for these individuals, especially eating partially cooked steaks, raw beef tartare or medium rare or rare meats is perhaps significantly dangerous. And so I caution people to understand that when you are on a proton pump inhibitor, it's even more important for you to understand how to eat properly and see the soonest and the earliest you can get off of the proton pump inhibitors. And it's very hard to get off of them because there's a rebound. When you stop it, there is a rebound increase in the amount of stomach acid that your stomach makes. And stomach acid is designed to be in the stomach. The stomach has a protective mucus layer so that the acid in the stomach will not digest the stomach itself. But this protective layer is not there in the esophagus. So any amount of stomach acid that regurgitates into the esophagus is going to cause severe symptoms of heartburn. Most people who get started on this are because they're starting it because of heartburn. And I wish that there were better methods and better understanding and education of heartburn to the general population so that the increase in proton pump inhibitor use is not so endemic and epidemic and widespread.
For somebody that's been on one of these PPIs for a prolonged period, how long does it take for the body to rebalance out when they come off?
The rebound is almost instantaneous. So, let's say you're taking PPIs, and even if you cut the dose to half, you can get a sudden rebound. So you have to train the patients to behave differently. You got to train them to say, avoid any food that is causing reflux. After you eat the food, don't lie down immediately. After you eat the food, don't strain, don't increase your abdominal pressure that would cause you to have reflux. Don't slouch and sit, in which you can get reflux coming. After food, maybe go for a nice and easy stroll being upright. So there are things that you need to train and teach these patients. Now, the extreme version may be to actually have surgery to prevent reflux, but that surgery is so specialized, it is so invasive, and so few surgeons know how to do it properly that you can really get into all kinds of problems. So these are things that perhaps an expert can manage for you, but I wish that the dangers of PPIs are educated to the general public in a better manner.
Right. The piece I was digging for there is over time, though, the body will bounce back and balance out, right? If they come off the drug.
Correct.
And how long does
Mhm.
that take before everything's functioning, quote unquote, normal again?
I don't know for a fact, but I think it's somewhere in the range of about 2 to 4 weeks.
Okay. The other piece that I want to address that ties into this as we start talking about going really low carb, having, carnivore, high meat, is insulin. And a lot of people in that world demonize insulin and want to keep it as low as possible indefinitely. You have a bit of a different twist on that, where it's about controlling insulin. So let's talk about somebody over time, they've gotten metabolically healthy, but say they're on a really low carb diet, ketogenic, all the way to carnivore, and they're not occasionally spiking that insulin. Problems that can occur there.
And let's kind of first take it from a standpoint of Dr. Roger Unger, who did some of the seminal work for us to understand insulin biology, insulin physiology, and how insulin and glucagon interact with each other. So, insulin is made in the islet cells, in the beta cells in the pancreas. And glucagon is made in the alpha cells in the pancreas. And these cells are juxtaposed to each other, they are right next to each other. Now, insulin has a very specific response, which is called a phase one response. So, when you eat carbs, there are packets of insulin that are already present in an islet cell, in a beta cell of the pancreas, and these packets are immediately released into the circulation. So there is a sudden spike in insulin, and this sudden rapid spike in insulin is one of the crucial mechanisms to the juxtaposed alpha cells for glucagon to get shut off. So when insulin is up, you would ask, why should I shut down glucagon? And that's a very important aspect because glucagon is catabolic. It's going and telling the liver to break down stored glycogen into glucose. It's going and telling the muscles to convert protein into carbs. It's going and using the glycerol from the fat to convert glycerol and did I say protein to fat? I said it wrong. It's telling protein to convert to glucose. That is what glucagon is doing. It's telling glycerol from the fat to convert to glucose. So glucagon is a catabolic hormone. Insulin is an anabolic hormone. Not only does it store fat, but it also makes the body make new protein. And it also makes new protein in the brain because the insulin spike in the brain is creating new protein, which is important for you to form new memories. I think memories in our brain are stored as protein. So it is important to understand that if you're metabolically healthy, why do you want to deplete your stored packets of insulin in your pancreas? Because over time, what happens is that if you are on a low carb diet, if you're on a carnivore diet, the pancreas says, I am not using these packets of insulin at all. Why should I make them? I don't need to make them. So the number of packets go down. So the spike in insulin goes away. The reduction in glucagon is not as pronounced. So the glucagon levels remain high. So you are remaining catabolic and you are not becoming anabolic and putting in new protein because you failed to have that rapid spike in insulin. So that's what I argue is that if you are metabolically healthy, why should an individual not periodically? And I don't know what the right answer to that is. Is it once a week? It's twice a week? It's 3 times a week? Or it is more times a week in which you should actually have that phase one, a rapid insulin spike, so that you are behaving like how our physiology was designed to behave and getting the benefit of insulin spike, reducing your glucagon, becoming anabolic, and doing many other benefits. So I don't know if I explained that properly or was it too technical there, Jesse?
No, that was perfect. I want to highlight here, we're talking about somebody who's metabolically healthy because insulin resistance is such a major challenge in society today. Almost everybody is suffering from it. But this is in the case where somebody's regained their metabolic health.
So when somebody is insulin resistant, they also lose the packets of stored insulin. Can you believe that? In other words, they are having to produce so much insulin to maintain homeostasis of blood sugar that they cannot maintain making those packets. So the packets are lost. One of the first manifestations of insulin resistance is the loss of that phase one spike in insulin. And when you lose that phase one spike, you don't drop your glucagon levels. And what do you think is going to happen if you don't drop your glucagon levels? You've just eaten a large meal, all kinds of protein and carbs are coming into you, and yet your pancreas is giving signals to your liver to keep making glucose. So instead of your glucose from your glucose output from your liver going down, it remains high. So the packets of insulin, the phase one insulin response is lost not just on a low carb diet, but it is also lost in insulin resistance.
Take that story even further. I want to make sure I fully understand it. So when glucagon in that case remains elevated, you're going to be catabolic, but you're taking in calories. So I'm picturing this massive amount of nutrition, energy in the system. What happens next?
It's metabolic mayhem because the glucagon should be shut off in order to prevent protein breakdown, in order to prevent glycogen breakdown, in order to prevent a further rise in your blood sugar. When glucagon levels remain high, the pancreas is getting signals that make more and more insulin, more and more insulin. And the increase in insulin over time, if your pancreas can keep up, is going to make you heavier and fatter and hypertensive, which means that as insulin levels go up, your blood pressure goes up, and you can get all kinds of diseases from high blood pressure. High insulin can cause atherosclerosis or plaque buildup. And so this is pure metabolic mayhem. And Dr. Roger Unger was the first one to describe the close relationship between insulin producing cells and glucagon producing cells, and how the interaction, the balance between how, as insulin is going up, how glucagon should come down is vitally important for our metabolic health. And so I find that story fascinating. He died maybe about 3 or 4 years ago, but he was an amazing icon, just like Dr. Joseph Kraft. I think Dr. Roger Unger has similarly done some very seminal work for our understanding.
And isn't it true when that's all happening and we're in this state of chaos metabolically, that you have all this energy, all this insulin around, that we start storing fat viscerally, we get fat deposits in different organs, and then all the challenges that go along with that?
Absolutely correct. I missed pointing that out, but I'm glad you brought that in. So what, Jesse, you're talking about is ectopic fat deposition. At some point with insulin resistance, the fat cells become overstuffed. When they become overstuffed, they cannot take any more fat in, and those fat cells become inflamed. So in other words, instead of just being quiescent, uh, not inflamed fatty tissue, they become inflamed fatty tissue, which is bad for you. Not only do they not take in extra fat, but the extra fat that is left in the bloodstream causes the very lipotoxicity that I talk about. And this lipotoxicity is quite significant because this fat is going to get into your pancreas, destroy your pancreas. It's going to get into your liver. It's going to cause fatty liver. And at the cellular level, it causes aging. So extra fat in your cells forms toxic radicals that go and destroy your mitochondria. And one of the ways in which you age is if you destroy your mitochondria, because when you destroy your mitochondria, you cannot burn fuel, you cannot use oxygen. So, lipotoxicity is potentially one of the mechanisms for aging, vascular degeneration, and organ degeneration. And that should be avoided at all costs. So, when we talk about increasing fat intake and going on a low carb, high fat diet, we are addressing metabolically healthy people. If you are metabolically not healthy, you have inflamed fat cells, you have ectopic fat deposition, you have high triglycerides. For me, the initial strategy, the way I would individualize these patients, is for them to focus more on exercise, on fasting, and a diet that is a lean, low carb diet, and rather than a high fat diet. And that is where I fundamentally am different than almost any low carb practitioner that I have come across, because I get a lot of hate mail and email when I talk about people in the beginning when they're metabolically not healthy to prioritize fasting and exercise and eat a diet that is a lean low carb diet until they become metabolically healthy and then start increasing their fat intake.
And we did talk about this last time, but I think it's important we get into it, at least in a general sense, a little bit deeper here. So what you're saying is for that first period of, I think it was about 6 months, we want
Depends
to
how
do,
young you are, how unhealthy you are, how old you are, but go ahead.
when we're metabolically unhealthy, while we're regaining that, we want to go low carb, high protein, low fat. Which again, the difference between what you're saying there versus a lot of the other practitioners is they would say go high protein, high fat. You're saying once you gain your metabolic health to a certain point, then we can bring the fat back in.
Absolutely.
So, how do we know when we get to that point when we can start bringing more fat in? Because obviously, everybody's coming to this at a different state of being metabolically unhealthy. How does somebody begin to clue in when they can start
Absolutely.
bringing more fat in?
And it's fairly straightforward and easy. Number one is that your triglycerides go down. Number two is that the quality of your LDL, instead of being small and dense, it becomes large and fluffy. Number three is that your HDL starts rising. Number four is that your insulin levels drop. Number five is that you have a change in your weight. Number six is that your blood pressure gets better. So there are several markers that an astute clinician can recognize and tell you what is happening to you is in the right direction, and it is point at which you can start increasing your fat intake.
Okay, and the other two pieces you brought in at that point in the beginning when we're metabolically unhealthy are exercise and fasting. So let's take some time and get into each of those. Starting with fasting. For somebody that is metabolically unhealthy, new to fasting, how do they begin that practice?
Fasting is a lot easier than many people recognize, because as you begin to fast, you exhaust your carb reserves fairly soon. And as you exhaust your carb reserves, these people already have high glucagon levels, they are insulin resistant, they are starting to do gluconeogenesis in the beginning. In other words, they are making glucose from fat and protein. They're also using up the stored glycogen in their liver and in their muscles. And as you fast, you start burning fatty acids in the muscles, you start making ketones in your liver. And fasting becomes a lot easier the more you practice it. So I would initially advise that, hey, try 12 hours and then kind of over a period of a few weeks. Some people can do it in a few days. Go up by an hour every day until you are reaching a point of about, let's say, 18 to 20 hours of fasting if you are metabolically unhealthy. I also think that people who come at a level which I would describe as a body mass index of 35, 30 to 35, severely insulin resistant, which means that their insulin levels are high. And in the presence of high insulin levels, they also have high glucagon levels, which means that insulin and glucagon are not talking to each other. Because remember, as the insulin level goes up, the glucagon should go down. They also have high A1C despite having high insulin. These people might benefit from a supervised 3 to 5 day fast. And when I say supervised, the reason it should be supervised is because fasting creates all kinds of changes in the body. And we can get into that as to what are some of the reasons why you need to be monitored. Your electrolytes may change, the levels of your cortisol may increase, the level of your epinephrine and norepinephrine, these are the fight or flight hormones, they may go up. So, long term fasting in my mind should be definitely supervised. Short term fasting, like 18 to 20 hours every day, so in other words, 2 meals or 1 meal a day, can perhaps be more easily accomplished without the degree of stringent supervision that would otherwise be necessary. And when you're fasting, many people think there's a group of people who think that fasting is very bad for you because of several reasons. One is that you are losing muscle mass, you're losing protein. That's one reason why people don't want you to fast. Number two, there is an increased risk of heart rhythm problems. You may get atrial fibrillation, you may get palpitations and stuff like that. The number three reason why people say don't do fasting is because it slows down your metabolism. And that's very important. You don't want to slow down your metabolism, you don't want to lose muscle mass, and you don't want to get palpitations. So let's take each one of these. As far as protein mass is concerned, I'm very happy to report that our body is so smart. And one of the reasons we age is because our protein gets senescent. In other words, protein becomes old, misfolded, malfunctioning. One of the reasons we get dementia is because there is protein in our brain that we have not bothered to clear up. And fasting promotes autophagy. It's going to get rid of junk protein first. It's going to help your brain because you're getting rid of junk protein. It's going to help your muscles because you're going to get rid of junk protein. There are studies after studies that show that fasting creates a spike in your growth hormone. Growth hormone is one of the anabolic hormones. So when refeeding starts, the high levels of growth hormone will let you deposit new protein. So I think that muscle mass loss should be put aside with this, at least with a traditional form of fasting. I'm not talking about losing muscle mass, which you will if you're insulin resistant and your insulin resistance is being treated with many of the drugs that would accelerate your protein loss, like SGLT2 inhibitors. We can get into that later if you want. Number two aspect is arrhythmias, and that is true. Because when you're fasting, your cortisol levels are going up. Why does cortisol go up? Because the body has to make glucose. And in order to make glucose, it's going to increase hormones that promote gluconeogenesis. So cortisol is one of the mechanisms through which you make new glucose. The levels of your fight or flight hormones, in other words, initial studies, seminal studies done in the 50s, 60s, and 70s have shown that the levels of the fight or flight hormone, which is epinephrine, norepinephrine, other names for that is adrenaline and noradrenaline, they go up. The urinary metabolites of these hormones go up. And these hormones have gone up to make sure that you have enough glucose to feed your brain in case of an emergency. So these are gluconeogenic hormones. But they also stimulate the heart and can cause heart rhythm problems or palpitations. So you are at a slightly higher risk of arrhythmias. And so that's something that you may want your doctor to monitor to see how much you are at risk and how fasting can be individualized. The third aspect is the slowing of your metabolism. And I would agree that metabolism definitely slows down with long term fasting. It has been shown. However, you can prevent the slowing of your metabolism by doing what I call as zone 2 exercise. So the question becomes is what is zone 2 exercise? Zone 2 exercise is exercise in which you are stressing your system, your cardiac system, to the point that you're using only fat as fuel, fat as energy fuel. If the exercise gets to higher intensity, you get out of zone 2. Your body is not just consuming fat, but it also needs to burn carbs. So, what is the body going to do if you go into zone 3, 4, 5, and 6? Is that it's going to jack up your cortisol levels, it's going to jack up your epinephrine and norepinephrine levels in order to make more glucose through gluconeogenesis, which is going to accelerate your protein loss. So, in order to avoid that, if you exercise at a heart rate which is roughly, this is perhaps the best parameter that Phil Maffetone talked about, which is 180 minus age. So, if you're 60 years of age, exercise at a heart rate that is less than 120. Another way to find that out is that you're exercising, but you can have a conversation with your friend without having to pause for breath. So, that's conversational pace exercise. So, with these three techniques, you can make your fasting safer. So, we talked about fasting. What was the other one that you wanted me to touch on?
Exercise in general.
Correct. So, we talked about zone 2 exercise already. And exercise is an important mechanism to improve your insulin resistance. In other words, insulin functions better. It's important for you to empty your fat stores because you will burn fat. And it's important for you to make new muscle because without stressing the muscle, one of the stimulus for making new muscle is not just eating protein, but by stressing your muscle. So, what should you exercise at? What level should you exercise at? If your goal is long term fasting, so in other words, you want to do fasting, you want to get weight loss, you want to get metabolically healthy, but performance is not a key aspect of it. Now, this is important. Performance. Now, performance is different. Now, here we are talking completely about health. If performance is not an aspect, be in zone 2 because you're burning fat, you're stressing your cardiovascular system, you're not increasing the levels of your stress hormones dramatically. The only downside of being only in zone 2 is that you're not stressing your muscles enough or your cardiovascular system enough to improve fitness and muscle strength. So, at some point, if fitness becomes an important aspect, put in 2 days, like if you're exercising 6 times per week, have a couple of days in which you are doing at higher intensity, going into zone 4, 5, and 6. So you're getting the fitness benefit and you're getting the strength benefit from it. So that's how I would modulate exercise and individualize it depending on what the person wants.
So coming back to that zone 2, you can take 180 minus your age and you want to keep your heart rate below that. How low can you go? Say you're going for walks every day for an hour with a friend. Is that enough? Coming from the bottom, I want to make sure we're at least getting, we've talked about it the other way, top down. But what is the bare minimum to get the benefit?
So zone 2 is very specific. What you're talking about is recovery zone, which would be, I would say, I don't know if it is a zone 0 and 1. Zone 2 is one in which you are burning fat at an accelerated rate than at basal rate. Like when I'm sitting down here like this, I'm still burning fat, but I have to accelerate that fat burn. And in order for me to accelerate that fat burn, I need to be as close to that 120. I mean, sorry, for a 60-year-old, as close to 180 minus age as possible, because not only are you increasing fat burning, but you're also giving signals, according to some literature, to make and replenish and keep your mitochondria. Because having mitochondria is important for you to maintain your metabolism and not reduce your metabolic rate. So, zone 2 exercise cannot be considered as just sitting down in one place or walking at a stroll pace in which your heart rate never gets beyond 75 to 80 beats per minute for a person 60 years of age. They need to get to between 110, 115. And some people are of that opinion that you should be as close to your zone 2 peak heart rate. Like for a 60-year-old person, it would be 120. There is another additional argument that the more fit you are, physically fit you are, the more endurance training you have done, that zone 2 starts going up. So, in other words, the peak of your zone 2 for 60-year-old may not actually be 120. It may be 125. It may be 130. Now, you would ask me, how would you know precisely? You would have to know that by doing muscle biopsies and seeing if you're producing lactate in your muscle. Because if you're making lactate, that's where you are turning from fat metabolism to burning carbs. So that you're getting, too much into the weeds there. But I would say for an average person, conversational pace exercise is best. For somebody who's a little bit more wanting to be in tune, 180 minus age is best to figure out your zone 2.
That does make sense, though, that the body would adapt and you'd have to push it a little harder over time. But no, that's good. You answered my question. I want to make sure we were pushing it enough because we did talk about the 120 or 180 minus your age being around that 120 for somebody 60. Somebody that, again, takes it all the way down to 75, 80, 90. You got to push it enough as well from the other end. So that's great. While we're talking about inputs, when we are talking about going low carb, keto, carnivore in that realm, depending on how far a person's pushing it, they're going to start producing ketones. And I'm curious your thoughts on producing ketones, at least periodically, as a stimulus input for the body and the importance, or if there is any importance of that.
There's a large body of literature that talks about ketones being a better fuel for us because they don't cause as much inflammation, that the brain functions better on ketones than it functions on glucose in terms of clarity and thinking, and that it is better for people to be in ketosis, especially when they have uh, bipolar disorders, seizure disorders, many neurologic disorders, maybe even for depression. And ketosis is one of the hallmarks of figuring out that you are activating autophagy. And autophagy is a very necessary component for us to remain healthy because we have to clear out junk protein from our body, from our brain, from our muscles, from our liver, from our pancreas. So I think that humans biologically were designed to be in ketosis. That's how we evolved. The overabundance of food, the availability of supermarkets was not the way our biology is designed for. I don't think we are designed to eat 3 times a day. I think we are designed to eat much less frequently, to go through frequent periods of fasting and frequent periods of endurance exercise, and also anaerobic exercise, weight training exercise, or resistance exercise. So I cannot emphasize that fasting, which and low carb diet, which results in ketosis, is a fundamental health promoting mechanism that we have to employ with periods of feasting that can also create health. So I hope that I was not trying to give an impression that ketones are not important. They are vitally important for our health.
No, I didn't get that impression. I was just curious what importance you gave them in the big picture here.
Absolutely.
Earlier, we were talking about insulin resistance. I think it was in that part of the conversation. You mentioned some drugs maybe we could get into later. Was that the Ozempic, Wegovy, those drugs? Was that what you were referring to there?
No, I was referring to SGLT2 inhibitors. So we can talk a little bit about SGLT2 inhibitors. I also have a talk on GLP-1 agonists, which is the category of Ozempic and Manjaro. That's also an important thing to touch on. So let's talk about SGLT2 inhibitors. And I think these are beneficial drugs. So I'm not going to say they don't have a place. But what SGLT2 inhibitors do is they cause glycosuria. So what glycosuria means is that you are peeing sugar in urine. Our body is designed to filter sugar into the kidneys, but there is a mechanism of reabsorbing the sugars from the kidneys before it becomes urine. So there is a protein in our kidneys which is called SGLT2, and it's a glucose transporter. So what it does is that it picks up a sugar molecule from the kidneys and eliminates a sodium molecule. So when you give an SGLT2 inhibitor, that means these are poisons that make that protein not function well. You eliminate urine, you filter urine into the kidneys, but you don't reabsorb it. So people taking an SGLT2 inhibitor are urinating about 150 grams, up to 150 grams of sugar in their urine. So if you say 4 grams of sugar is roughly a teaspoon, then they are eliminating somewhere in the range of about 35 to 40 teaspoons of sugar in their urine. So that's an astounding amount of sugar that they're eliminating. Animal studies have shown that when you go on SGLT2 inhibitors, that the body increases gluconeogenesis. So what gluconeogenesis is that to compensate for the sugar that is lost, the body converts protein to sugar. So in other words, you will have muscle mass loss. So indiscriminate use of this drug without proper explanation to the patient and without properly informing them how to improve their insulin resistance is likely to cause muscle mass loss with these drugs. So these drugs, although they are beneficial, should be used in the right setting, with the right advice, with the right methods of improving insulin resistance rather than just giving a drug and not paying attention to lifestyle. Another downside of this drug is that they can become very dangerous. So I have several people who come in towards the end stages of their diabetes. What does that mean? End stages of diabetes means that they have been insulin resistant for so long that they have stressed their pancreas for so long that the insulin making machinery is almost completely destroyed. In other words, they're not making much insulin at all. So, in these individuals, when they go on an SGLT2 inhibitor and they're not making enough insulin, one of the ways the body compensates for the lack of sugar is to resort to fat metabolism. In an ordinary situation, that would be very good. Using fat, resorting to fat metabolism is good because you're burning fat and that you're emptying the fat cells, that's good. But in this situation, in the absence of insulin, the ketone levels go up dramatically. So this is called diabetic ketoacidosis. And I don't know if you have heard about it, but this happens in type 1 diabetics. Type 1 diabetics don't make any insulin at all. And our body has a defense mechanism that as the ketones rise, like let's say I'm not a diabetic, I know I'm not a diabetic. And if I do fasting, my ketone levels will go to about 4, 5, maybe even up to 6. But they will stop at that point because if they go up further, my body will make insulin and keep the ketone levels down. However, if somebody is a burnt out type 2 diabetic, they are not making enough insulin to regulate their ketone levels, and these ketone levels can rise and cause euglycemic ketoacidosis. In other words, the sugar levels are okay because they're peeing sugar in urine, but their ketone levels climb up dramatically. And you may have seen some commercials that talk about, did you get ketoacidosis on SGLT2 inhibitors? Why don't you call this lawyer? We can do a class action lawsuit and stuff like that. So that is the genesis of that.
Okay, just so I
So in my
understand, this is
practice,
all new to me. I'm glad we're getting into this. It sounds like anytime you're on this drug, you're going to lose protein, you're going to lose lean mass. And then if you're in the later stages of being diabetic, you could be under threat of going into ketoacidosis.
but there is a benefit for that when it's rightly used, because you're going to turn from glucose metabolism to fat metabolism. So I'm not discounting the use of these drugs. But what I'm saying is that if you're given this drug without you being counseled on how to improve your insulin resistance through diet and lifestyle and fasting and exercise, I think it's fundamentally wrong. So I think that when a patient comes to me and is on an SGLT2 inhibitor, I think it's extremely important for me to check their insulin levels and make sure that they're making enough insulin so that they don't get into euglycemic ketoacidosis. That's one of the fundamental checks I do. I don't take them off of these drugs. I explain them how to use them to their benefit. At this point, maybe we should consider transitioning to that GLP-1 agonists.
Yes, and you did a great talk on allulose that I've watched on YouTube. Let's talk about Ozempic, which is the drug everybody's talking about these days, being the GLP-1 agonist, and then this natural sweetener, allulose, and the similarities there.
Sure. So Ozempic is a fascinating drug. As we eat food, unfortunately, we don't have very good mechanisms for us to say we should stop eating. And our biology is designed like that because our biology was designed in an era of scarcity. We didn't have enough food around, and having mechanisms for overeating created a survival advantage. So, a person eating food, what happens is the food gets digested starts the digestion process in the stomach, then further digestion happens in the duodenum, and then it reaches the later part of the small intestines, which is called the jejunum. So at the level of jejunum, which would be several hours after you have eaten, like 90 minutes, 2 hours after you have eaten, the body is then giving signals because there are K cells and L cells in the jejunum that make a compound called GLP-1. So GLP-1 is a very specific compound that does the following things. It makes your stomach stop emptying. So in other words, your stomach feels full because your contents stay there. It happens to me, it happens to a lot of my patients. I'm eating, my stomach is hurting, and yet I have this desire to overeat. I have this desire to continue eating. And I used to wonder, why is this happening? And the reason it's happening is that my biology is designed for me to overeat. I was asked to overeat because it was a survival advantage. And then I reach about an hour and a half later, and my stomach feels even worse. And I'm saying, why is that? I mean, I wanted to eat more. I stopped because my stomach hurt. But now it's an hour and a half later. The food should have moved and my stomach should feel less worse. But it's feeling worse because now the GLP-1 has kicked in. It's telling my stomach to stop emptying. It makes me feel even fuller. And so the mechanisms to stop eating are delayed, and they are later and later, perhaps, than it should be for our environment that we live in, with overabundant food, engineered food, highly palatable food, whatever you want to call it. I can make food that is a super normal stimuli for me to overeat. Even me. I mean, I don't even have to go to food engineers and food industry to blame them for that. The second thing that GLP-1 does is that it goes and talks to, and I think these are the pleasure centers of the brain, and it improves satiety. It improves, it reduces hunger. So you're not hungry, it reduces your hunger, it slows down your gastric emptying, and then it has a few other effects. It improves pancreatic beta cell function, it regenerates the pancreas that's making insulin. So it's a great thing, but the GLP-1, the half-life of that is relatively short, few minutes or something like that. So the drug company is very good at extending the half-life of this agent. So they take the GLP, they add a fatty acid chain, then they add another residue that prevents it from being removed by the enzymes that remove it in our body. So initially it would last for like 24 hours, but with further fatty acid modifications, further modifications in the residue at which the peptidases that degrade this GLP-1, they become resistant to that. So it's now lasting for a week. So when you take a GLP-1 agonist, you're not hungry, your stomach feels full, you eat less. And so I said, this is fantastic. This is something that is evening the playing field. And our biology is designed for 50,000 years ago. Now we are living in a different era. We have this constant barrage of stimuli that are coating our dopamine neurons, wanting us to overeat. Can GLP-1 level the playing field? And I think it does. And I think these are useful drugs when used properly with the right degree of instruction to the patients for them to start improving their metabolic health. Because when you take a GLP-1 agonist, studies have clearly shown that these things happen. Number one, your blood pressure drops. Many people are hypertensive. Number two, your triglycerides, which is fat in blood, reduces. Number three, your HDL, which is a clearing mechanism for atherosclerosis, which is called a good cholesterol, goes up. Number four, your insulin levels drop. So you become more fat burning, you store less fat. Number five, over 1 year time, you can lose about 10 to 15% of your body weight. So why not use that in patients who are appropriate for it? So I do prescribe this drug. I tell them that watch my YouTube video, look at some of the side effects of these drugs as to, the three side effects that you're paying attention to is nausea, vomiting, and constipation, because it's slowing down your gut. You don't want to take it to the point that you're nauseated, you're constipated, and you're throwing up. You want to keep the level of the drug much lower. The second and the most major problem with this drug is an off ramp. How do you get off of it? Because once you get off of it, are your feeding mechanisms going to come back? In other words, are you going to start, eating more and regain the weight? And you are, going to not have any slowing of your gastric emptying. So studies have shown that when people stop this drug, they regain 60% of the weight that they have lost in the first year, which is very devastating. But new data is beginning to emerge, not solid, it's anecdotal, it's empirical, that if people have honed in on fasting, exercise, and a low carb diet, the off ramp becomes a lot easier without the regain in weight that you would expect. The fourth issue that I have explored in my practice, and anybody who comes on this drug to my practice is asked this question: do you lose the pleasure in eating? Because eating is a pleasurable activity. And if you are going to take away your dopamine neurons or the activity of your dopamine neurons, you can perhaps lose the pleasure in eating. But many people come back and tell me that their quality of life improves. And the reason their quality of life improves is that having better self control over their food choices and not being or being able to resist temptation and have better willpower gives them a sense of well being. It makes them feel better about themselves. So I've hardly come across any person who tells me that they lose the pleasure in eating. They say the pleasure in eating is there, but the excess munchies, the overconsumption is gone. So I am not against these drugs. I think that these drugs should be used, but they should be used with a proper instruction on what they do, how they work, and how to use them to your advantage.
Okay, my pushback is why not just use the diet, exercise? What was the third? Oh, fasting component. Is this for a select population? How do we determine who it's right for? Is it a band-aid for somebody that could be applying the lifestyle and diet stuff? How do you look at that?
That's a very good pushback. So the way I counteract that is three ways. Number one is that you have given this advice to people on three separate visits about 3 months apart, and they have tried their best and they have failed. And you tell them, hey, go do the same thing over and over again. So, in other words, try the same that you have failed 3 times, try it a fourth time or a fifth time. So, they need to have an additional tool in their toolbox through which they can improve and modulate their health. Number two is that we have to recognize that we are all very different. My dopamine neurons may be not as good as yours. In other words, I might be more susceptible to temptation. Dopamine neurons, when they are coated by food industry, by the food that I prepare, or by anything else in my environment, may be firing in such a way that I am destined to a life of overconsumption and addiction. And I may not be able to deal with that without some additional help. So in other words, I'm just evening the playing field between the environment and the person. And then when I see all the dramatic health benefits, in other words, increase in HDL, drop in your triglycerides, drop in your blood sugar, drop in your blood pressure, drop in insulin levels, drop in weight, it becomes a little hard to argue that you should not use it in people who have failed the traditional diet, exercise, and fasting guidelines.
Okay, my other pushback, when you start messing around with dopamine, what if that affects other areas, like your drive for work or other areas of life?
Yeah, dopamine is a very strong drive hormone. It's a wanting, it's a movement, it's an action hormone. It's not a pleasure chemical. It's something that makes us do things. It provides us with motivation and energy. And if it's doing that, then yes. But when I talk to my patients, their improvement in quality of life is dramatic. Like, for example, I go home after 12 hours of work, and you would expect that I would say, okay, I should rest, I should sleep. But I'm media addicted. So I go to YouTube and I'm scrolling the YouTube channels, trying to find something that would provide me a dopamine hit. So that's addiction not pleasure. And our environment, our current day environment, is full of signals that are coating our dopamine neurons. And how do we even that playing field? Can we even it just by recognizing what's happening to us? And yes, maybe some of us can do that. Do some people need a touch of help? I cannot tell you how many healthy young men come to my office and say they take a little bit of Manjaro, which is an Ozempic like drug, just to take that edge off and make them behave better in terms of discipline and focus. So I'm giving you a pushback in the other direction.
So they're
I
not
think,
just laying around on the couch playing video games all day.
correct. So dopamine neurons can get you to drive and do excellence, but dopamine neurons can also get you addicted to bad things in which you're just sitting around and playing video games and taking in tubs of ice cream.
All right, I want to respect your time. I know we're already pushing it here, but I'll end on this because I already brought it up. Allulose. So this is another pushback. If we know this has a similar effect, why not use something like that versus a drug? So talk about the differences there.
Very good question. So let's talk about allulose a little bit. So the simple way to describe allulose is that it is fructose. Now, fructose is a 6-carbon molecule. And I think, I'm not sure, at carbon 3, you have oxygen at one side and a hydroxyl group at another side. So you take an epimerase and you flip it. So what it does is that it is absorbed. It's about 50% as sweet as table sugar, I mean, regular sucrose, and maybe 50 to 75%. It is absorbed, but it doesn't enter any oxidation. It doesn't enter the glycolytic pathway. So, in other words, it's not burnt. It doesn't get converted to fat, so you don't store it. And you eliminate it unchanged in urine. So, it's providing you with a sweetness. It is not burnt or stored, which is fantastic. And unlike the other sweeteners, it does not have an aftertaste. It is as close to real sugar as possible. Now, there are some animal studies that show that when you take an allulose, that you stimulate the L cells and you increase GLP-1 levels. So in other words, it's like you are taking an Ozempic-like drug every time you eat. Unfortunately, there are only rat studies that show that. There is not any animal study that shows that. So I have been giving allulose to a number of my patients. I ask them, how well does it work? So they say, as a sweetener, it works fantastic. As an agent that is curbing their appetite and making them eat less, the jury is still out. I want to see human studies that are showing that allulose is actually increasing GLP-1 levels rather than having to rely on rat studies alone. If my clinical experience with the drug, in other words, giving it to patients and them coming back and telling me that, hey, it works fantastic, is just not corroborated yet. And in fact, I think it's leaning in the other direction in which people say, no, it doesn't really curb my appetite. So I don't want to push the compound that much. I think it's a good sweetener. It's probably the least harmful of all the sweeteners.
All right. Well, the jury's still out, but we'll have to follow up and see what you're seeing with patients longer term. But Dr. Ali, great conversation. Really enjoyed round number 2. And we're going to link up your website, your social media, everything in the show notes. Thanks for coming back on.
Thank you, Jesse. I hope you didn't waste 2 hours of your time and your audience time by talking to me again. I hope it's useful.
Oh, it was. Thank you.
Thank you. Take care.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
If I put food into my mouth and it goes into my stomach and my GI tract, no matter what the food is, it's going to drive inflammation because inflammation is the body's natural protection against foreign material. Fructose.